Hello, everyone. Welcome to RegenMed Global, the podcast, where we bring you the top doctors and researchers in the world leading the newest breakthroughs in medicine. My name is Shayan. Today, we're here to discuss a clinical trial for Metformin as a potential treatment for primary progressive multiple sclerosis. Involved in this study, we have Dr. Kevin Patel, neurologist at UCLA. Dr. Patel, it's great to go and have you. Thank you for joining.
Well, it's wonderful to be here,
Um,
Shane. I'm very happy to be a part of this podcast.
Thank you. Thank you. Before we get started, do you mind telling us a little bit about your background and what you do?
Yeah, so I'm a neuroimmunologist at UCLA. I'm a part of the neurology faculty there. I'm a professor at the university, and I see patients with a variety of autoimmune conditions that affect the brain, the spinal cord, the optic nerves. And a lot of my practice is focused on helping patients with multiple sclerosis, with all forms of multiple sclerosis. Much of my training is in research, both in neuroimaging work as well as in the performance of clinical trials. I come from a long research background, but I spend a great bit of time working with patients just in day-to-day care at the same time.
That's awesome. Now, this clinical trial that you're involved in and you're leading, can you give us an overview of this study?
Absolutely. So what I'd say is that multiple sclerosis is a field in which there has been an enormous degree of development as far as therapeutics are concerned. There are many, many drugs that have been developed over the past several decades. We've made an enormous amount of progress in terms of treating patients that have MS. There's two ways in which MS causes problems, and the way that the developments that have occurred have primarily been to address the inflammatory component of the condition. So, as you and many in your audience may know, it's common when it is that patients have MS for folks to have new inflammatory attacks or relapses. When this happens, patients can have sudden onset symptoms that begin rather abruptly and then develop over the course of days, over weeks. And then sometimes improve over the course of weeks, over months. The medications that we have now, they're very good at preventing that kind of a problem. But there's this other aspect of MS that we don't have a great answer for. The medications that we have currently just don't work well for the second aspect of MS, and that's progressive MS. And when patients have progressive MS, they have gradually accumulating permanent disability. So, there's not an abrupt onset of symptoms. Folks often don't realize that something is changing from day to day, but over the course of long time spans, over the course of many months, many years, patients notice that they have had a gradual worsening in their walking or gradual worsening in their eye movement. So this second aspect of MS, progressive MS, is an aspect of MS that despite all the sorts of developments that we've had, that we don't have a good answer for. So the trial that we are running here is a real effort to address that aspect of multiple sclerosis, the progressive aspect of multiple sclerosis. We're looking at a compound called Metformin. So Metformin is a medication that's based on compounds that have been well known about for over 100 years, that are derived actually from a French flower, from French lilac, that in the 1990s were developed to treat diabetes. So this medication has become one of the mainstay treatments for patients with significant diabetes. It's a first-line treatment, and it works rather well. And we understand the risks from having used this medication for several decades now in that context. There has been a great bit of excitement for Metformin in progressive MS for a handful of reasons. One is that it's widely been found to be neuroprotective. There are actually trials running in Huntington's disease and Parkinson's disease at the same time, as well as in precursor conditions to Alzheimer's disease. Second is because it also has a wide set of anti-aging properties independent of any disease. And there seems to be this close relationship between how it is that MS develops in age that we don't completely understand. So, just to give you a few examples of that, when patients develop MS as children, when folks have pediatric MS, they virtually never have progression. And depending on regardless of the time that a person develops MS for the first time, progression usually emerges in a person's 30s and their 40s and their 50s. So, whether you develop MS in your, as a 40-year-old or whether you develop it as a 10-year-old, usually progression doesn't emerge until that sort of age. And so there's some sort of a relationship with age that we don't completely understand. Could this medication has anti-aging properties help? And then third, and probably most importantly, it's done rather well in animal model work. And so we give mice with MS, a model with a condition that's very MS-like, metformin, and the animals do considerably better when it is that they're given metformin. We find that when it is that animals are given metformin, that it downregulates one type of gene that causes more in the way of inflammation, in the nervous system. And so these are the motivations for the medication. We've essentially organized a trial where it is that we're recruiting patients with this progressive MS, and we're going to treat them for over the course of about a year or so with medication. And we're collecting really, really high quality MRI scans on a high fidelity machine you developed for the purposes of this really large nationwide effort called the Human Connectome Project. We're doing really detailed cognitive testing on patients, and we're doing detailed physical exams on patients at the same time. And we're going to look to see, does giving a person metformin, does it help them as far as it is that these imaging markers are concerned? Does it help them as far as cognitive testing is concerned? Does it help them in terms of their physical exam? And further, we're also looking to ensure that there's not any special risks with the medication when it comes to a population of patients that has multiple sclerosis. We don't expect that because our patients, diabetes is very common, and it's very common for many of my patients to have diabetes. They take this medication otherwise sometimes for that, and we don't see any particular risks associated with that. But we want to be sure before it is that we launch a much, much larger multi-center trial that that's the case, that it's a safe medication.
Excellent. Dr. Patel, have you started administering this treatment on any patients yet?
We're a good third of the way through as far as recruitment is concerned, and so there are a number of patients that are already enrolled in the trial. There are a handful of patients that have been taking the medication for about 7-8 months at this point, and so the trial is ongoing and recruiting in full force at the moment.
Excellent. Would you be able to share with us kind of any kind of outcomes that have come so far from the treatment within the clinical trial?
Yeah, so an important thing about clinical trials is that we try to do our best to not bias the results of the clinical trial, and so a big part of that is to do what's referred to as like a blinding or a double blinding. And what that means is that there's not many people in this trial that know what it is that they're being administered, whether they're being administered the metformin or whether they're being administered the comparator, which is essentially a placebo. So half the patients in the trial are going to receive the metformin and half of them are going to receive the placebo. But until it is that the last patient finishes their year-long course, we don't know actually who it is that's taking metformin and who it is that's taking placebo. And the purpose of that is to ensure that there's nothing that I do or anybody else in the trial does or patients do that changes based on our knowledge of which medication they're taking. And what this means essentially, though, is that we won't be able to really analyze the data to look to see as to whether there's an effect from the metformin until it is that we're unblinded, and that won't happen until the very end. So the only folks right now that know who's taking metformin and who are not are the folks that manage the data, and we've hired some doctors just to take a look at safety parameters to make sure that the medication is not causing any safety issues. They know that who's taking metformin and who's not, but other than them in the pharmacy, no one knows at this point who's on metformin and who's not.
Are there any potential benefits that you expect patients to go in and see by using metformin?
Yeah, absolutely. I think that we'll likely see improvement in certain cognitive outcomes, and we'll likely note that certain areas of the brain are better preserved and have less in the way of atrophy. I think at minimum, folks in our population have a significant cardiovascular disease that occurs through the course of the population, both in patients that have MS and don't have MS. The medication almost certainly will help those patients in terms of preventing new brain injury from those sorts of concerns. So I expect at minimum we'll see that. But the likelihood is that in addition to that, we'll also see an MS-specific effect, and that we may see less in the way of new lesions, we may see less in the way of brain atrophy in very particular areas.
Do we know kind of ideally how long it would take if someone was to get benefits, how soon they could see benefits, and how long those benefits could last for by using a treatment like this?
Well, the hope is that they're permanent. The hope is that the benefits will last. Like the hope really is that we'll find medication, hopefully metformin, that stops progression or slows it considerably. And the disability that that person would have accrued over the year, we hope to prevent that. So it is that at least while it is that they're taking the medication, they don't accrue that sort of disability. And so, we would hope that the effect for the medication would be permanent. It wouldn't be the sort of thing that we would expect the person stops taking the medication and all the sorts of change that they would have occurred over a year would like accrue all of a sudden. We would hope that, for that period that they were taking the medication, that that they would have some slowing as far as it is that the disability is concerned.
Sure.
So it would be, the hope is that regardless of whether folks stop the medication or not, that at least the effect that it would have had over that course of that year would be something that stays with them. That would be the goal of this. I think that we wouldn't consider it a successful sort of study if it was just sort of a temporary benefit that the person had while it is that they were taking the medication that sort of went away when it is that they weren't on the medication. And
Okay. Now,
your first question. Oh, go ahead.
Yeah. Yeah, and then so is this something that they'd be getting like a one-time treatment, or is it every so often that they'd be getting the treatment?
Yeah, we're administering it in a way that we know is safe from our long experience in using this medication with diabetes, and from what we know as far as it is, and when it is that patients start running into side effects, on the medication as well, from past clinical trials and also from our experience using this out in the real world in that other condition. We're administering the medication twice a day, essentially. So folks take a pill in the morning and they take a pill in the evening, or two, because we've cut the pills down into half the dose. That's often used. So they took 2 pills in the morning, 2 pills in the evening.
Okay. And then, yes, in terms of the previous question, like how soon could someone see benefits from, let's say they take the first treatment, right? Does it happen immediately, or does it take time?
Yeah. So this is a big problem as far as it is that studying progressive MS is concerned. Because it is that the changes that folks experience from progressive MS are so slow to accrue. It's not like a relapse where it is that a person just wakes up and they may notice that their right arm and leg is weak, or it is that they may notice that their vision in their left eye is no longer present. It's blurry, or they can't see color in the way they could just the day before. In progressive MS, the changes accrue very, 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 very slowly. So it's hard to tell, even in any given person, whether the changes are even occurring over the course of a few weeks or over the course of a few months. Our hope is that that over the course of about a year or so, that we would be able to notice that sort of a change. That the person was not accruing disability over that sort of time frame. But just the nature of the condition, because it is that it's imperceptible from day to day, from week to week even, the sort of changes that it causes, this new sort of disability that it produces, it's hard to give like a more defined sort of time frame.
Okay. Do you know when we can expect for the results to be finalized and shared?
Yeah. So we're about a third of the way through recruitment at this point. We have about we're recruiting at a healthy pace, actually, at a much more aggressive pace than we anticipated. And that we budgeted for. Many people are actually interested in the trial and are contacting us on a very regular basis. I'd imagine that over the course of about a year or so, we will have. I don't think it'll be longer than a year before it is that we've completed recruitment for this study. And once it is that the last person is recruited, it'll be about a year or so before it is that they've taken their last dose of medication. So I anticipate roughly about 2 years or so. It could be less than that if it is that we recruit at a much faster pace than what I've sort of outlined.
So let's say if this is successful, could this open up opportunities for utilizing metformin for other conditions as well too, beyond PPMS?
Yeah, I think that this study is looking at all progressive MS, so secondary progressive MS and primary progressive MS, folks that have progressive MS, and I'd imagine that if it is that it was approved, there'd be a lot of interest. If it is that this is successful and a wider effort is successful, that that there would be interest in looking to see as to whether we could prevent it from occurring in the first place, in folks that are high risk for developing like a progressive multiple sclerosis, folks that have, let's say, relapsing remitting MS with risk factors for progressive MS, or clinically isolated syndrome with risk factors for progressive MS. There'd be interest in seeing as to whether we could help those patients as well, and so you could see there being like academic interest in essentially organizing a study to investigate those sorts of populations. It also would give the argument that this medication is neuroprotective a little bit more in the way of heft, right? And so these studies that I briefly mentioned that are going on before in precursors to Alzheimer's disease, in Parkinson's disease, in Huntington's disease, you would wonder as to whether they'd be more likely to be successful because it is that that it is proven successful in multiple sclerosis. So those are ways in which it may be immediately relevant to other efforts in other conditions outside of progressive multiple sclerosis.
Dr. Patel, this is really valuable information. Is there anything else that you'd like to add, or any other final thoughts?
No, I think that's a very, very exciting sort of thing, because it uses a medication that for which we have like 3 decades worth of safety data essentially, and we know that is like rather well tolerated to address like a rather large problem for which there's no other treatment, and no other satisfying treatment essentially, so it'd be a sort of a solution for this that doesn't involve, if it was successful, it'd be the sort of solution that involves very little in the way of risk, certainly far less risk than what it is that our most effective treatments for relapsing remitting MS have patients take on, so it'd be a rather elegant way of addressing the problem. And I think that it's even before it is that we had all those treatments for relapsing remitting multiple sclerosis, when it is that we did these natural history studies where we watched how it is that patients did over the course of their lives, what we found is that it wasn't actually the relapses, even in those patients that were causing like the bulk of disability. It's primarily progression. These studies done back in the 80s and the 90s, it's primarily progression. And so if it is that this was successful, if it is that it's successful, it would represent a much bigger breakthrough than even the sorts of very highly effective treatments that have been developed basically thus far, because it would address much more in the way of disability that exists out there than those treatments would or do.
Dr. Patel, this is very exciting. Thank you so much for your time.
Of course, it's fantastic to be here. It was really a lot of fun sharing our work over here about Metformin and all the excitement that we have for it.